All right, good morning, everyone. We're just about to start. This morning's virtual cardiac rounds will be presented by our esteemed colleague, Dr. Jim Cherry. He will be presenting on the ESC updates. Dr. Cherry, it's all yours. Thank you.
Great. Well, thanks for everybody attending this morning. And the European Society for Cardiology meeting was again a virtual meeting this year. And I know Dr. Mukherjee and I usually go, but haven't been able to do that for several years now. Next year we'll be in Barcelona, and we'll be either virtual or in person, depending on what's happening with the pandemic at that time. So the purpose of this review is just some of the data, because there are so many excellent studies that there's only so much I could bring up. So I figured I'd look at several different areas and limit it to 3 for now, with looking at one of the premier studies was the which was highlighted throughout the meeting discussions, was in heart failure, and the use of, in particular in one study, was empagliflozin in preserved ejection fraction heart failure. And then this was reviewed in several different areas. And as we know now, there's this concept of foundational therapy in heart failure, at least with reduced ejection fraction. But we never had a proof of another agent before this being actually having true response for patients with preserved ejection fraction. There's some new data which was interesting in lipid management after ACS, especially as at the Centenary site, there's aggressive intervention in lipids right after ACS in hospital. And there's a new agent coming up, which is a non-steroidal mineralocorticoid receptor antagonist. And I'm going to look at that and how much does it work in CKD, CHF, cardiac patients. And so there's a lot of studies on dual antiplatelet therapy, but I really didn't think we had enough time to go through all of that. Then there's the usual disclosures, having over the year or years honoraria from many different companies that are actually have products that are listed in the different sections of the presentation today. So we'll start off with Emperor Preserved. All of these slides were basically downloaded off the internet, just so that you know. Some of them you'll see a company name on, just because it's they uploaded it that way from the ESC site. So basically, empagliflozin has had a extensive study program over the years, and we all remember EMPA-REG and the impact that that had on our cardiac patients back in when it was originally published in 2015 and evolving over the years. Then 2 years ago, the Emperor Reduced trial was released, which was the use of empagliflozin in patients with reduced ejection fraction less than 40%. This was complemented subsequently as well in another agent using dapagliflozin, showing similar results. Of course, patient populations are always different. This newer trial, Emperor Preserved, is looking at patients with preserved ejection fraction, is a larger trial and was designed to be complementary in the types of patients entered, except for the ejection fraction, to the Emperor Reduced trial. And then there was a post-trial analysis putting all the results together that I'll present as well. And there's a couple of more studies in their trial program coming. We will be seeing more data over the next year to 2 in the use of dapagliflozin in similar types of situations. So we're all looking forward to that. So heart failure, we've always used reduced ejection fraction less than 40%. And then we had called the 41 to 49% mid-range, but now is called mildly reduced ejection fraction, and preserved ejection fraction is above 50%. And then heart failure with improved or recovered ejection fraction is patients who are initially low who then improved. So we have all these areas to work with, and then we have this question of what works in who, and where should our cutoff actually be for treatment with different drugs in terms of what their ejection fraction is. So we know that the HFpEF patients have had poor outcomes, and we have had many studies over the years, none of which have shown any conclusive evidence for treatment benefit. And a lot of the patients have heart failure with preserved ejection fraction, and the mortality is fairly similar to those with reduced ejection fraction. We had the closest version of a treatment that may have worked was in the TOPCAT trial using spironolactone, I believe it was, or eplerenone, and that showed benefit in only subgroups, but this was, again, just giving you an idea whether this could work or not, because the main trial was neutral or no benefit. And I'll mention a little bit more about that later in one of the other trials that I'll be presenting. So this is the design of Emperor Preserved, and looking at empagliflozin versus placebo in people with preserved ejection fraction. And this is both in diabetics and non-diabetics, such as was in the Emperor Reduced, people over the age of 18 with chronic heart failure class 2 to 4, and they were divided into either treatment versus placebo. And the primary endpoint was adjudicated CV death or adjudicated hospitalization for heart failure. And there were secondary endpoints as well. And so I think it's interesting to note that unlike many of the trials, almost half of the people who were enrolled in this trial were women. They weren't particularly overweight. There is a real trend toward more Caucasians being entered in the trial, being well balanced, even though the total of people from North America and Europe were about 56%, 76% were Caucasian. This could be due to the entry in people from both Asia, from Australia, as well as Caucasian members from Latin America. But I can't define that as this data was not available. Everything else was pretty well balanced. The ejection fraction measures were about a third each of 40 to 50, 50 to 60, and greater than 60, which is important. The NT-BRO and proBNP was positive in these people, and it was largely people with non-ischemic heart failure versus ischemic being 2 to 1. And like many other trials, the great proportion of the patients, over 80% in each group, were class 2 in nature. So this is treating people who have mild, not severe heart failure. They all had on average reasonable renal function, and atrial fibrillation was common in half of the patients, as was diabetes in half, and 90% in each group had a history of hypertension. Because of that history and other factors, especially in the mid-range people, I would expect that the use of renin-angiotensin blockers, as well as Entresto were about 80%. Over a third were on MRAs already, and beta blocker use was very common at just under 90%. So this is the main result. So this is, again, this is the first time that we've seen a significant risk reduction by treatment of a drug in people with preserved ejection heart failure. And the curves we can see separated from the beginning with an absolute risk reduction over the 36-month of total follow-up of 3.3%, giving a number needed to treat of 31, which is fairly reasonable. And so this was quite significant and of certainly importance to us in our treatment paradigm because of never having an agent before that had benefit in this group of patients. We can see here from the forest plot that everything was on the empagliflozin side. Of course, the size of the purple dot that we can see reflects the number of patients that are in that group. The smaller the dot, the more likely it is to have wider confidence intervals because the numbers are that much smaller. And this is similar in showing that the benefit is in the baseline EF, particularly under 50%. It's maintained in the 50 to 60% as well. And if you look at the subgroup of over 60%, which was 1/3 of the patients, this crossed the unity line and therefore was not as significant. It didn't matter whether you're diabetic or not, what your renal function was like, and likely no difference whether you were class 2, 3, or 4 because the majority were in class 2 and 3 and 4 were small in comparison. Whether you were hospitalized recently or not, and there was probably no difference what the cause of your heart failure was. There's no difference in as well how high your NT-proBNP was and whether you were or not were on an MRA before entry. And having atrial fibrillation or not made no difference at all. So the main benefit was in reduction in hospitalizations for heart failure by 27%, which was one of the main predefined primary endpoints. They looked as well, having examined this in other studies, what happened with the renal function, and there was a slight difference in slope overall during the double-blind period, and as we can see at the beginning, there was a drop in the empagliflozin group in the eGFR, but that is part of the expected outcome in use of an agent such as this. But what's important is there is a difference in the slope, and the slope looks at the decline in renal function, and the slower the decline, even though the numbers are small, can make a difference of years in terms of progression to end-stage renal failure. This showed significant benefit both in the primary and the key secondary outcomes, as we can see from the column on the right side. Primary outcome reduced by 21%, heart failure by 27%, and less renal decline. So, what pushes our results? So if we look at this, the primary outcome gave us the numbers in order to have a statistically significant reduction. The individual components, the event rate was numerically reduced, and the p-values, however, were not quite as good. because of the numbers being smaller. Another key point is that there were trends that occurred in the groups, is that the Kansas City quality of life scoring was better. However, this did not meet statistical significance. The hospitalizations for any cause was down, but again was very close, with just going over the unity line. And the other numbers were too small to make any major difference. Unfortunately, this did not show a significant difference in all-cause mortality in this study in comparison to the Emperor Reduced, which did have a statistically different number. The patients might like the fact that there's a trend for decreased body weight, as we can see in the third line, losing almost 1.4 kilos in comparison to 0.1 kilo. And there was a slight drop of just over 1 point in the blood pressure, but again, not statistically significant. So lots of people had minor side effects. The people who were in the treatment group actually had slightly fewer serious adverse events. Hypotension occurred slightly more in the treated group, renal failure less. And importantly, there was no difference in ketoacidosis. There was a slight increase in genital infections in light of its causing so much sugar in the urine. And critically, for use of these agents, there was no significant adverse effect leading to lower limb amputation, being actually less in the treatment group than the placebo group. So this being an important trial, the summary we would look at is that we have to remember in our patient treatment groups that we see in the heart failure clinic or in our offices, about half of patients have heart failure preserved ejection fraction. And they continue to have adverse outcomes, and this can reduce the primary endpoint in these patients of CV death or recurrent hospitalization for heart failure, on top of what we do now of just trying to control their volume, heart rate, and blood pressure with our other agents. So this the safety data shows that it's well tolerated, and it's consistent with treatment in the heart failure reduced trial. So it looks like there may be a benefit across the whole spectrum of heart failure. Then interestingly, subsequent to the major presentation, Milton Packer, who's of course very well known in heart failure management, presented the pooled data. So this is not a randomized trial, but it's an analysis of the results, pooling the patient data together from the reduced and the preserved trial. So this gave 9,700 patients with 3,500 from the reduced EF and the rest from the preserved, and looking at the outcomes. And it was consistent in his analysis that the reduction of the primary endpoint in both was fairly similar, of 21 to 25%. Time to the first heart failure hospitalization down by about 30%. Cardiovascular death, even though the numbers were small and non-significant, was down by just under 10%. And total recurring hospitalizations for heart failure were down by high 20s. So if we look back, it's important to look back at what was going on and which patients were going to benefit. So let's think of what's in the red box, which is the 40 to 50, 50 to 60, and greater than 60% ejection fraction. And we can see that there's a significant difference, that the under 60s seem to have a significant benefit, whereas when you get over a 60% ejection fraction, it looks like that benefit is lost in the Emperor Preserved trial. So if we go back to the Paragon heart failure trial using Entresto, in that trial, the benefit in the patients from of all patients and the patients from in the 40s and the 50s seemed to be significant, and again it was lost in that group once the ejection fraction went over 60%. Fairly similar findings were found, and of course we can't make a trial-to-trial absolute comparison in terms of hazard ratios because there are different patients entered into each trial, but we can see that the trend in the Paragon trial of Entresto in heart failure was similar, but a different absolute number because of the different types of patients, and that there seems to be a benefit in the 40 to 50 as well as the 50 to 60% ejection fraction patients by significant reductions of 10 to 20% if you divide it up like this, and then the benefit is lost once you get above 60%. Fairly similar concept in time to first heart failure hospitalization, and a bit of a scattergram being not really significantly different at all for cardiovascular death because of the size of the trials not being powered. So this again looks at various subgroups, and this is the pooled data from across the Emperor Reduced trial and the Emperor Preserved trial, and then we can see that if we look at the heart failure hospitalizations in the first time, which is in the green dot, and total plus recurrent in the purple dot, that it's fairly consistent across from 25% or lower up to about 60%, that the benefit is maintained, and when you get above 60 to 65, there's no benefit anymore. So these patients seem to be quite different from the patients under 60%. And there was some talk that in at least women, that having an ejection fraction of less than 57% meant that they may be able to have some benefit of the other agent, Entresto, in terms of their heart failure hospitalization. So we have heart failure in general having benefit, and the 30% risk reduction that we see is a relative risk reduction, of course, but as the ejection fraction increases, you have a slight decrease in the absolute risk reduction, which is why you start to see less benefit, especially when you get into the high 50s and especially over 60%. So there was a difference, interestingly, in the smaller trial, which was the Emperor Reduced, showing the benefit in major renal outcomes, having a lot less in the treated group, and in the Preserved larger trial with no significant benefit. And the exact reasoning for that likely has something to do with the effect of significant reduction in cardiac output in the Reduced trial, but that has not been adequately defined and requires more study to assess the reason for relative lack of benefit in this larger trial. So heart failure outcomes are significantly beneficial in terms of treatment in both the Preserved and Reduced trial. We now have evidence with empagliflozin, evidence with dapagliflozin will be coming within the next year, and perhaps I believe there are some trials being presented at the AHA in November. and then the renal outcomes were seen in the reduced trial, but not the preserved, so this has to be assessed further. So I think we have a significant benefit that we've seen with this. I'll proceed now on to some interesting data on PCSK9 inhibition in people who come in with acute coronary syndrome. So this trial was led out of at Melbourne, Australia, and they actually managed to finish the trial despite the fact that half of it was done after the start of COVID. It was probably a little bit easier for them because a lot of their main recruiting sites were in Australia and New Zealand, but they did have some worldwide studies as well. And so we've had many patients treated with intensive lipid lowering, and we know that after an ACS that use of high dose statins has been shown to reduce the outcome of, or adverse outcome, I should say. So those do produce some plaque regression, and then the question is, does the use of extra agents to completely reduce the lipid pool even more make a difference in the potential outcome? So this was a study looking at a surrogate outcome, which is the fibrous cap thickness, because of data which suggests that if a fibrous cap thickness is improved, then there is a decreased adverse outcome. So they actually managed to get 161 patients into this and had screening, cath, optical coherence assessment, and they were randomized to either placebo or evolocumab and treated for a period of time, and then they had another OCT and IVUS at the end of the study. So these are people who had a non-STEMI, had definite CAD, had LDL greater than 1.6 on treatment with high intensity or greater than 2 on low to moderate intensity, and then were treated either with placebo or evolocumab, and looking at what happened to their fibrous cap and how much lipid they had. So this is what they did. So the fibrous cap thickness can be measured by OCT, and then the lipid pool, which is in the artery wall, because of the difference in the imaging of the lipid pool, what is called the lipid arc, which is basically, if you think of the lipids being like an oval pool within the wall, you can measure from one end of one oval to the end of the other end of the oval and get this percentage arc. And then you can look at what happens to all of these. So they had their OCT done, and then they were treated. They didn't lose too many patients because of different reasons, especially COVID. And they had fairly similar numbers of a total of 135 people who completed the trial, who had images initially and at the end. So how did this look like in terms of our usual patient population? Well, there's, again, as we see in many trials, there's a smaller percentage of women who are in the groups, and it was 70 to 75% male between the two groups. They're not big because it's a technique assessment looking at a surrogate endpoint. They weren't heavily overweight with an average BMI of 28. About 60% were smokers, and only a quarter had been on statins before treatment, but virtually everybody got a statin during the trial, and most were on high intensity. So here's what happened. As you would expect, that during any trial and observation, if you go from 25% of the patients only being on statins to start, and you put them on high intensity statin, their cholesterol definitely goes down. So we can see that in the placebo arm, that there is a significant reduction. If you look at the evolocumab arm of the trial, of course, you get the expected much further reduction in the LDL cholesterol. If we think back, let's just go back to that for a second. If we go back to trials from years ago, such as the Asteroid trial, the benefit in terms of regression of plaque that was determined by IVUS at that time was when you got the LDL cholesterol below 1.8. So despite high intensity treatment in this group, they didn't actually reach that threshold in the placebo arm. It could be because of the duration of treatment before the patients were entered, which was fairly short, however. So they matched pretty well with the same fibrous cap thickness at baseline. The lipid arc, or how much of lipid was seen in the artery wall, was fairly similar. And the lipid-rich plaque was high at 90%. So this is the primary endpoint, what happened with the fibrous cap thickness. And when you reduce the cholesterol by that amount with the some reduction in the placebo group, you get some increase in thickness of the fibrous cap. And if you really reduce it strongly, you get double the increase in thickness of the fibrous cap. Looking at changes as well, similarly, the percent change in the minimal thickness is quite different and doubled, and the maximum lipid arc is reduced in both groups, but reduced almost twice as much in the evolocumab group. So this says that there's a definite decrease, and as you're expecting, when you reduce the cholesterol a lot more, that you have the cholesterol is able to be brought out into the arterial system, and the lipid pool decreases with lipid reduction, which is what we would expect. So it demonstrates what we expect, and the stronger way that you're able to do this, the more effect that you get. And this looks at the change in the cap according to the whether it's the achieved cholesterol. So the lower you get, the better cap you get. And if you go from a higher cholesterol to very low, as we can see, the change in the absolute LDL rather than looking at the achieved LDL, the people who start with a really high cholesterol and get it really down, which would be at the minus 200 drop in the LDL cholesterol on the left-hand side of the right panel, we can see that that's where you get the most increase in the fibrous cap thickness. So, being a small trial, even though there was more deaths and non-fatal MIs in the placebo group in comparison to none in the evolocumab group, the numbers are too small in terms of the total trial only being 135 patients to make any comment on this, other than it's hypothesis generating. The injection site reactions, it's interesting that the people who got placebo injected had injection site reactions, whereas none in the evolocumab group. Myalgias were similar, and discontinuations were more in the placebo group than the evolocumab group. So, addition of more intensive lipid lowering with the addition of evolocumab is able to, for 12 months, resulted in more increased thickness of the fibrous cap and decrease in the amount of cholesterol within the vessel wall, and it was well tolerated. So this is, in general, it's a we're looking at a surrogate endpoint to say that while the benefits are well established now and have been shown in other trials, we know that it seems to be safe, and early reductions in cardiovascular risk may occur, and that vulnerable plaques may be and can be stabilized after an acute coronary syndrome. And this could motivate in further intensive lipid lowering in patients early post-ACS, as is being looked at with some study at the Centenary site in particular after ACS with stent implantation after a STEMI. So again, this is a surrogate being plaque thickness, but we know from other studies that the fibrous cap thickness really makes a difference in terms of plaque stabilization. Thus, we would expect this would likely reduce the actual MI risk in these patients, and further study with a larger number of patients may likely be required, and I expect there's more data to come. So we'll finish off with some data on an agent that's not used or approved currently. And there were 2 studies presented at the ESC on this agent, and I think it's something that we should all know about as it is coming up in the near future. So this is an agent called finerenone. Finerenone is a mineralocorticoid receptor antagonist, but it works in a different way. So we know that people who have CKD and diabetes have a higher risk of hospitalization. And here is the graph that has been developed over time with different studies looking at CV mortality or heart failure in people as their ejection fraction drops. And whatever the cause of their ejection fraction dropping, as it goes down, their CV mortality risk goes up, as we can see. If we look as well, this is something that we don't think about or even bother measuring because we easily get the eGFR when we ask for a blood test, but we actually have to ask them to pee into a bottle as well to get the urine albumin creatinine ratio, the ACR. And if we look at what the albumin creatinine ratio is, if it's under 5, there's no problem, but after that, it starts going up with a linear increase in the cardiovascular mortality and the risk for heart failure as well. And you have a lot of patients who don't have a decreased eGFR, who have a high ACR, who are at significant risk. And I think that we should start thinking about including this in our regular testing. So finerenone is a selective non-steroidal MRA. So the difference is that it blocks more at the molecular level of the mineralocorticoid receptor in comparison to the steroidal blockers such as spironolactone and eplerenone, which act much higher. So spironolactone can cause the sexual side effects because it pushes a lot of the steroids into the estradiol pathway, which is why they can have the this effect. The eplerenone acts at a different point and doesn't cause an increase in steroids going into the estradiol pathway, and therefore they don't tend to get the sexual side effects of breast tenderness or enlargement that we see sometimes with excuse me, spironolactone. So this acts more down at the receptor level rather than higher, and that's why it's called a non-steroidal, because it doesn't act up in the steroid pathway effectively, to try to make it simpler. So this is part of a phase 3 trial looking at use of agents in people who either had low GFRs or albumin ratios. There are several studies done in this to try to differentiate whether the kidneys were better or worse with this agent when there was a lot of albumin, moderate kidney disease, whether there was only moderate albumin and minimal kidney disease, and there were overlaps between the two of these different groups. I'm not going to go into detail about the kidney disease because that's sort of a side interest rather than primary for a cardiology group. But the thing is that people were, there were many patients who were screened. It's a 7,400 patient population randomized, which is certainly big for something that's mainly a diabetic kidney disease group. They usually don't get so many patients. And these were looking at people who had renal disease, had moderate, very high urine albumin creatinine ratio, who were able to tolerate a RAS inhibitor and had normal potassium levels and could not have uncontrolled blood pressure and could not have HFrEF. So they could have had a history of HFpEF, but not HFrEF. And this is a cardiac outcome trial looking at, in diabetic kidney disease patients, what was the cardiac outcome of CV death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. And they looked at the kidney stuff as well, and I'm not going to get into that here today. So they had well-controlled blood pressure, long-standing diabetes, 14 years. A1C wasn't too high at 7.7%, and just under half had a history of some type of cardiovascular disease. 7 to 8% had a history of heart failure, but the HFrEF patients were specifically excluded, so this was a HFpEF trial in a way. And they were on the usual range of treatment for their diabetes and underlying cardiac disease with, as would be expected, if you have diabetic nephropathy with significant albuminuria, pretty well everybody was on a RASI, and a high percentage on statins, and sort of 50% beta blockers, calcium blockers, and diuretics. So urine albumin creatinine ratio is an important indicator for kidney damage. And here, as we can see, 60% of patients had a significant increase in their urine albumin levels, with the mean GFR being maintained. And what happened in this group? There was a significant reduction, not huge for a cardiac trial, of 13% in the time to CV death, non-fatal MI, or hospitalization for heart failure in the treated group of people who are on good treatment for underlying cardiac disease in this patient group. So this was after 3.5 years. The NNT was a bit higher in this trial at 47. So the outcome was primarily driven by the reduction in hospitalization for heart failure. So this is interesting because this is a non-steroidal MRA, and even though it's a secondary endpoint, this hospitalization for heart failure was reduced in patients with HFpEF. So this is an implication that proper use may actually improve the patients with HFpEF having decreased hospitalization. No big difference in cardiovascular death, no change in MI or non-fatal stroke. So it's pretty safe. There was a slight increase in hyperkalemia, but rarely led to discontinuation, and very rarely led to hospitalization and never caused death. There was actually more hypokalemia than hyperkalemia if you look at the right-hand side. So the drug actually does slightly increase the potassium, but in general, it's only by a small amount over the entire trial length, and was persistent while people were taking the drug. It actually didn't make much of a difference in blood pressure, only dropping the blood pressure by 2.7 millimeters. In contrast to spironolactone, which can actually be fairly potent as a blood pressure dropping medication in many of this type of patients. So it's not great on blood pressure, but it certainly has a benefit in what we would tend to care about, which is the hospitalization for heart failure. So there's no off-target effect. There was less hypertension, but slightly more hypotension, but nothing had a big effect, and the overall difference on blood pressure, as mentioned, was very small. It didn't affect A1C, and as you wouldn't expect it to significantly affect that. So there's a benefit in heart failure hospitalization. There was some effect on the kidney outcomes if you took the strict definition that the nephrologists use, which is a greater than 57% in eGFR. And adverse effects were fairly similar. So I think that this shows that we do appear to have a significant benefit for heart failure with preserved ejection fraction in people who are diabetics. And we will look forward to the ability to treat these people better, and there will be more trials upcoming with finerenone in people with heart disease rather than just diabetic kidney disease. So we'll look forward to those, and eventually this agent will be approved and will likely become an addition to our armamentarium. So it's interesting to see where things are going in the future rather than just now. I won't get into any more data on this at this point. And so again, it's an effective treatment perhaps for cardiovascular and kidney protection in people who already have significant CKD. And we should look at urine albumin independent of what their eGFR is in order to see who may benefit for treatment with MRAs, especially this new agent when it becomes available. So I said at the beginning what we're going to look at, and we looked at that, and we saw that we now have evidence that empagliflozin has benefit up to an ejection fraction of 60%, but nothing beyond that. And we've seen in the Australian-based trial that marked suppression of LDL post-ACS improves the fibrous cap thickness and may well have a significant effect on plaque stability and decreasing recurring acute coronary syndrome. And that we have this new agent that's coming up that we certainly need to know about and may have a big reduction in heart failure in patients without reduced ejection fraction. And this is a significant contrast to TopCat. And so there'll be more information to follow. And this agent is not yet improved, and will be interesting to see what happens in the cardiac trials, which will be coming. So I'd like to thank everybody. And are there any questions?
Thank you, Dr. Cherry, for this morning's presentation. We'll move into the question and answer period. We'll leave it open for a couple of minutes. Just a reminder for those who maybe came in halfway through the presentation, this morning's rounds have been recorded, so they'll be up in a couple of weeks on the site that I did put a link up in our chat box. And then you can ask Dr. Cherry a question either using the raise your hand function, or you could type it into the chat. Thank you. We'll leave it open for another minute, and then we'll let everyone get on with their day. All right, Dr. Cherry, I don't believe there's any.
I think everybody's signed out there.
Yeah, I don't believe there's any questions. Thank you for this morning's presentation on the update, and thank you everyone for joining, and we'll be back next week. Have yourself a good rest of the day.
Thank you.